Hello students, I'm the OGGuru Dr. Punit Bhojani and welcome to the INICET 2024 recall session, and I'm very happy and thanks for all the messages which you have sent in that sir, each and every MCQ in the INICET was from your video lectures and your notes. So thank you very much. And for the students who haven't yet downloaded the OGGuru app, please download the OGGuru app and get in touch with me. I'll be guiding you which is the best and most suitable package for you. And there is a rapid revision MCQ discussion package which is only rupees 448, and within few days your entire OBGY preparation will be done. So those who are targeting the upcoming NEET PG examination and the FMGE examination can go for this rapid revision MCQ package, which is available only at rupees 448. So do download the app, get in touch with me on the phone, and I'll be guiding you. I'm personally guiding all the students how to study, how to prepare. The upcoming NEET PG exams would also be from our teaching and our notes and our lectures only. Okay, so let's begin the discussion. Yes, okay, so we discussed this in our lectures. So point number one, we have got a patient who has got a LMP 2 months ago or 8 weeks. So she is in the first trimester, and now with bleeding PV and hypotension and shock, altered sensorium. So what is our dictum? Yes sir, shock in early pregnancy is ruptured ectopic unless proven otherwise. Okay, shock in early pregnancy, first think of a ruptured ectopic pregnancy, and that is what it is. Okay, this free fluid in the pouch of Douglas on USG is also the hemoperitoneum, because when the ectopic will rupture, there is going to be blood, hemoperitoneum, there's going to be blood in the pouch of Douglas. Placenta previa is bleeding in the third trimester. It's a part of your APH. Placenta previa presents with painless bleeding in the third trimester. Okay, threatened abortion, patient will not go in shock, hardly slightly bleeding, spotting. Okay, and missed abortion, again there are no symptoms. Now when you do the scan, just the heartbeat is absent. So these two patients will never go in shock. Yes, incomplete abortion, patient there's more bleeding and patient can go in shock, but the answer over here is ruptured ectopic. And also cervical movement tenderness, many students told me was present in the question. That is again a hallmark sign. I told you, cervical movement tenderness. And if it is a unruptured ectopic, we also get fornicial tenderness, and we can also feel a pulsatile mass. Okay, so cervical movement tenderness, fornicial tenderness and shock, all these are signs of ectopic pregnancy. Ruptured ectopic, what is the dictum? Yes, immediately 2 wide bore IV lines. Okay, quick in, quick out is the dictum. Isn't it? Clap if you feel happy. Quick in, quick out. And please remember, what is the gold standard? Sir, salpingectomy. Salpingectomy is the gold standard surgery when there is a ruptured ectopic pregnancy. So shock in early pregnancy, shock in the first trimester, please first think of ruptured ectopic. Okay, is it understood to all of you? Yes. And these two patients, they will not have shock. There's hardly any bleeding and spotting in missed abortion, threatened abortion. So I hope all of you have got this correct. It is a very simple, straightforward MCQ. We had discussed it in our lectures. Okay, yes, again very important. Okay, I had predicted that this question will be coming. Topic of preeclampsia, eclampsia. Now here BP 170, 100, 36 weeks and headache, blurring of vision. So can anybody tell me what is the diagnosis? History of convulsion, I'm not sure whether some student told me it was present, it was not present. Management will not change. Okay, so if of course history of convulsion is there, then it becomes eclampsia. But if that history of convulsion, even if it's not there, what it is impending eclampsia. That is our diagnosis, impending eclampsia. Why I am saying impending eclampsia? Because of our dangerous signs and symptoms, headache, blurring of vision. What are the other things which you need to keep in mind? Oliguria. Okay, headache, oliguria, blurring of vision. nausea, vomiting, epigastric pain. Okay, so all these things may also be given in the question paper. And now what we know, okay sir, when there is impending eclampsia, we are not supposed to wait and watch. Remember, I told you माँ और बच्चे में से माँ को बचाना है. Mother is more important. So let the patient be 26 weeks, 30 weeks, 32 weeks or 36 weeks as it is over here. The answer will not change. Whatever may be the weeks of gestation, but in impending eclampsia, first we give magnesium sulfate. Why? This is given prophylactically to prevent convulsion. Okay, so point number one, give labetalol steroid and deliver at 37 weeks. Sorry, you cannot wait and watch. Never wait and watch. Okay, in such patients, never WW. Okay, we are not supposed to wait and watch. So never wait and watch is the dictum over here. So that option is gone. Again, labetalol and only experiment wrong. Never and yes. Okay, labetalol and deliver immediately, say better. Okay, labetalol and deliver immediately, but better is of course magnesium sulfate has to be given. It has been proven that when we give prophylactic magnesium sulfate, it prevents complication, it prevents eclampsia, and of course labetalol to control the blood pressure and expedite delivery. And we of course go for induction of labor. Vaginal delivery is what we try. So therefore option number C is the answer. I hope all of you. So we immediately give impending eclampsia, or if it is actual eclampsia also, it is magnesium sulfate and then immediate delivery. Why? Because delivery is the definitive treatment. Delivery is the definitive treatment, and the delivery, please write down in brackets, irrespective of weeks of gestation. So in this MCQ, instead of 36 weeks, even if the question is 32, 33, 28 weeks, the answer will not change. Answer remains the same. Okay, because again remember student, after giving magnesium sulfate, you can never wait and watch. Okay, so you can never wait and watch. You have to go for delivery, immediate delivery, irrespective of weeks of gestation. That is extremely important. You need to keep that point in mind. Okay, it is immediate delivery, irrespective of weeks of gestation. Please draw 4 slides, 4 stars around this word. Okay, moving on to the next important MCQ which was there. Yes, again, so happy that RH negative, very few students know the concept. Please go and see the video. Extremely important points are taught to you. We have a patient who is O negative, husband O positive, anti-D given at 28 weeks. Can anybody tell me what is this anti-D given at 28 weeks? Yes, routine antenatal anti-D prophylaxis, RAADP. Okay, what is RAADP? Routine antenatal anti-D prophylaxis was given to her. This is based on the assumption that the baby is positive. Okay, now after delivery what? So always after delivery we are supposed to do the baby blood group. If the baby is negative, nothing is to be done. If the baby is negative, if the baby is born RH negative, negative blood, even if it goes in negative mother, there is nothing to be done. So after delivery we are supposed to give anti-D only if the baby is RH positive, and of course provided the baby ka DCT is negative. And also remember, keep in mind that here the dose is 300. Okay, so we give a complete dose at 28 weeks. Also we give 300 IU, and your this also after delivery also the dose is 300. Okay, so complete dose is given. And remember one more point, that even the ICT is for the mother. ICT should also be negative, because if the ICT is positive, then there is no role. Okay, ICT positive means the mother is already formed antibody. That means the antibodies are already present. So the ICT is positive, antibodies are already present, and then there is no role for anti-D. No role for anti-D. Okay, So keep in mind that the mother is Rh negative, husband is Rh positive. At 28 weeks, we routinely give anti-D injection, and after delivery, we should do the baby blood group, and within 72 hours, okay, as soon as possible, but within 72 hours, we give anti-D injection to the mother if the baby is positive. Let it be any positive, O positive, A positive, whichever is positive blood group, then we should give anti-D. DCT should be negative in the baby, and ICT should also be negative in the mother. ICT for the mother. Okay, so moving on to the next MCQ. Yes, again I had predicted. If you see my reel on Insta, we had given the prediction, and this again prediction came 100% to. Primary amenorrhea is given to you. Breast is very well developed. Okay, pubic hair is also very well developed. Okay, so now please understand, many students got Kalman syndrome is what? It is GnRH deficiency. So here the breast development will not be present. Kalman syndrome, because this is lack of estrogen. Okay, gonadal dysgenesis is my Turner syndrome or ovarian dysgenesis. Okay, AIS androgen insensitivity is 46XY. So that is out. And in androgen insensitivity, pubic hair and axillary hair will be absent. So here pubic hair is present and 46XX. So this is Mullerian agenesis or your RMKH, Rokitansky-Meyer-Kirschner-Hauser syndrome. Now the points about this, please understand this. I'm so happy. I discussed an MCQ in our lectures where I had told FSH was 6. One of the MCQ FSH was 6. So please keep in mind that this FSH 5 is normal. And why the FSH is normal? Because sir, master servant relationship. That sir, in Mullerian agenesis, the ovary is perfectly normal structurally and functionally. So when the ovarian function is normal, the FSH is bound to be normal FSH-LH. Okay, so if the FSH-LH, can anybody tell me what will happen in Turner syndrome? Turner syndrome, sir, because it is streak ovaries, FSH will be very, very high. Is it understood to all of you? And in Kalman syndrome, by the way, there is GnRH deficiency. So here the FSH is going to be very, very low. Okay, and besides, breast development will not be there. So basically, primary amenorrhea, in fact, this was more simple. 46XX was the clue given away. Okay, if it's primary amenorrhea, well-developed breast, well-developed axillary pubic hair, that is your Mullerian agenesis or RMKH syndrome. Okay, in your androgen insensitivity, breast will be well-developed, but axillary pubic hair will be absent. Here, pubic hair is absent. Okay, pubic hair will be absent, and besides, the karyotyping is 46XY. And gonadal dysgenesis or Turner syndrome, again no breast development, FSH is very high. So remember students, this is a very important that when you get, remember FSH, when I say normal anything, remember 4, 5, 4 to 15, 20, 4 to 15 is considered normal. Okay, even 3 to 15. Okay, when they will say FSH low, na, in the exam FSH low, they will remember less than 1. They will say FSH is 0.5, 1, 0.2. So FSH less than 1 is considered low. Okay, and when they say FSH 20, 30, 40, that is very, very high. Specifically when the ovarian function is completely over, FSH goes more than 30, 40. Okay, so please keep in mind, this is very, very important. So it's extra information given, but students got confused. Okay, sir, what is FSH value? Whether 5, 10, is it normal? Yes, 5, 10, 15 is considered normal. Okay, so in RMKH, the important thing is that because the ovarian function is normal, FSH is bound to be normal. Okay, so I hope that is absolutely crystal clear to all of you. Kalman syndrome, there will also be anosmia. Anosmia, even if it is not given in the question paper, but remember, breast development will not be seen in Kalman syndrome because there's going to be estrogen deficiency, because GnRH deficiency, so estrogen will not be there. FSH will be very, very low. Moving on, yes, I'm so happy. And what is the trick? Clap if you feel happy. The total dose. Okay, please understand this, that the total dose of steroids, what you need to keep in mind, total dose of steroids is 24 milligram. That is what you need to keep in mind. That's the total dose. Now what is our trick? A, B, C, D. Okay, two steroids are there, betamethasone and dexamethasone. A, B, C, D का मतलब क्या है? B is the second alphabet, so 2 doses. And dexamethasone D is the fourth alphabet, so 4 doses. Clap if you feel happy. Okay, so now you know, okay, sir, 24 divided by 2 is 12 milligram. 12 milligram, 2 doses, but 24 hours gap. Okay, and dexamethasone D is the fourth alphabet, so 4 doses in total. 24 divided by 4, each is 6 milligram. 6 milligram, 6 milligram, 6 milligram, 6 milligram, but at the gap of 12 hours. 12 hours. Okay. So it's just an example. Suppose today morning I give the patient injection at 9 a.m. Again tomorrow morning at 9 a.m. we give. And suppose here what is done? 9 a.m. Then again in the night you give the injection 9 p.m. Then 9 a.m. this 9 p.m. And steroids are done for RDS prevention, for prevention of RDS, and also they decrease the risk of intraventricular hemorrhage. So now all of you know this. Okay, sir, betamethasone will not have 4 doses. Wrong. Okay, dexamethasone 6 milligram 12 hourly 4 doses. That is the answer. Dexa I don't give 24 hourly, and beta I give 2 doses, but it is 24 hours apart. Okay, so you have to choose. So they will always give you confusing option. Remember, betamethasone has 2 doses, dexa has 4 doses. Okay, so 24 hours apart is beta, dexa is 12 hours apart. So keep in mind, and this is a repeat MCQ, again likely to be coming in the upcoming exams also. Moving on. Yes, again very happy, this was also given to me by me in the mock test, that which is possible, which is not possible in twins. The question is not possible. Okay, so all of you know that all the dizygotic twins are dichorionic diamniotic. Okay, dizygotic twins, that means 2 eggs 2 sperms, they are going to be dichorionic diamniotic. 2 separate placentas, 2 separate amniotic chambers. Okay, now monozygotic twin means 1 egg 1 sperm to begin with, and depending on the, so 1 egg 1 sperm fuses, and now depending on when the splitting will take place, they are of 4 types. Okay, they are of 4 types. If the splitting happens in the first 72 hours, then again they are DCDA. If the splitting happens between 4 to 7 days, then there is same kitchen. Placenta is the same, kitchen is the same, monochorionic but diamniotic. Okay, this is by the way the most common variety of monozygotic twin. Okay, if the splitting happens between 8 to 12 days, monochorionic monoamniotic. And the least common variety when this twinning happens after 12 to 13 days, that is called as conjoined twins or Siamese twins. Okay, so common sense over here is that, sir, MCMA possible? Yes, possible. Dichorionic diamniotic possible? Absolutely possible. And monochorionic diamniotic is also possible. In fact, it's the most common variety of monozygotic twin. You can't have dichorionic and monoamniotic, so not possible. Dichorionic monoamniotic is not possible. Okay, so all dizygotic twins are dichorionic, but reverse is, but monozygotic could also be dichorionic. By the way, this is 80% of the time. Monozygotic is 20% of the time. MCDA is the most common type, or variety of monozygotic. Okay, remember that. MCDA is most common type of monozygotic. So MCDA is also possible. DCDA and MCMA is rare. Conjoint is the least common. Okay, so DCMA not possible. Okay, is it clear? Monochorionic placenta is the same, two separate chambers, or monochorionic same flat, same room also. You have to stay only in one room. Monochorionic, monoamniotic. Okay, by the way, DC dichorionic twin lambda sign, monochorionic twin diamniotic we get a T sign. Okay, so keep that also extra information I'm giving you. Okay, moving on to the yes, again very important. Now here caput is present, primigravida. I think it was also mentioned primigravida, 40 weeks. She is pushing for almost 2 hours, so prolonged second stage, good contractions, 4 contractions. Okay, and fetal bradycardia also, so it's fetal distress. What instrument? Okay, now I'm so happy. Station +3. What I told you, all the mid cavity forceps, high forceps, outdated kachra dustbin. Okay, so all of you should know what is the meaning of the word station. Station is in relation to ischial spine. Ischial spine is considered station 0, and 1 centimeter below it, +1, +2, +3, +4, +5. I'm so happy to discuss this. Okay, and when the fetal head is at station +2, then only, so station should be minimum +2. Okay, for me to apply a forceps is the ACOG guidelines, that is the low forceps, and when the head is further down, +3, +4, +5, okay, that is the outlet forceps. Okay, so low forceps is at station +2 and outlet is when there is station +3. Okay, and remember this, that when the higher stations, we don't apply the instrumental delivery. One of the most important statement, that in modern day obstetrics, station should be at least +2 and below. Okay, so now if you see, of course station +3, then outlet forceps. Now why not ventus also? Please understand that there is fetal distress. In fetal distress, forceps is faster. Okay, forceps is faster, and in forceps faster compared to vacuum. Okay, so vacuum will be less preferred. It's not that you can't apply, less preferred. Okay, and besides there is also caput, so the vacuum may not fit properly, or the vacuum will cause more slippage of the vacuum and more complications. So outlet forceps, basically they're asking you which instrument, outlet forceps. Okay, forceps faster than vacuum, and when time is of essence, forceps is preferred. Ventus less preferred. Okay, less preferred in fetal distress. Okay, so please keep in mind. Okay, and all this high forceps, mid cavity forceps, outdated kachra dustbin. Kachra dustbin matlab not to be applied, not to be done. Okay, because they're causing more maternal complications. Okay, yes. Again, very important, hypertensive patient, which drug is not used? Okay, so I have told you triple H. Clap if you feel happy. Thoko tali. Okay, what are the triple H for contraindications? 3 absolute contraindications for the use of methergine or methyl ergometrin. And triple H. First H is hypertensive disorders, or if in the option it is preeclampsia, eclampsia. Second, heart disease. Okay, heart disease you never give, because sudden increase in preload, afterload, heart disease patients can die. And as I told you, my mnemonic, half delivery of twins. Okay, it is twins after first baby delivery. Remember that if only one baby is out, and if I give methergine, second baby will have fetal distress and rupture uterus, and the second baby can die. After both babies of twins, yes, methergine can be given. So you remember it as twins after first baby delivery. But just to remember, I want to make it H, half delivery of twins. Okay, half delivery of twins. half delivery of twins means twins after first baby delivery. So this triple H, and you know the answer is methyl ergometrin. Oxytocin of course can be given. Misoprostol is PGE1 analog, that also can be given. PGF2 alpha can also be given. Which condition PGF2 alpha should not be given? Bronchial asthma. Yes, if they tell you that patient has bronchial asthma, then contraindication is PGF2 alpha. Okay, here it is hypertensive patient. Methyl ergometrin will not be given because it will increase the blood pressure. It's a vasoconstriction. It's going to increase the blood pressure of the patient. So heart disease patients, hypertensive. This is heart disease. Okay, very simple MCQ. And this. Yes, so happy. Yes or no? Were you happy when you saw this question? Because with the picture, with the diagram we had given, primary amenorrhea, this is actually your cryptomenorrhea. Question of cryptomenorrhea. Okay, urinary retention you get, and cyclical abdominal pain and suprapubic bulge. Okay, so as all of you know, now two things, please understand this, that longitudinal vaginal septum is not going to cause you, longitudinal vaginal septum is not going to cause you your cryptomenorrhea. Many students got confused. Yes, transverse vaginal septum can cause this, but because bluish hue on the vaginal wall, yes, that is your bulging hymen. Okay, bulging hymen. And what is the treatment? You take a cruciate incision. Cruciate incision. So imperforate hymen. Basically, it is, we have discussed this in my lectures also, that sir, what is happening is that the uterus is like this, the menses will start, but the hymen is imperforate. So blood gets collected inside the vagina. That is what? Hematocolpos. Hematocolpos, that will press the bladder and give rise to urinary retention. And then the blood gets collected inside the uterus, which is your hematometra. And also these patients have got more chance of developing endometriosis, and that is the reason when this blood will get collected inside this, that is the tense bulging hymen, and cruciate incision is what you put on the hymen. So this is imperforate hymen. Cyclical abdominal pain tells me very classically that sir, periods, she's getting periods but the blood is not coming out. That is cryptomenorrhea. They present to us with always primary amenorrhea. Okay, moving on to the next question. Yes, which is not a IUGR criteria. Now please understand this, slightly difficult MCQ, but nevertheless understand that IUGR is diagnosed when the birth weight or the AC is less than the 10th percentile, or birth weight less than 10th percentile for the gestational age. Okay, and also if any point of time, if the AC and EBW is less than 3rd percentile, that also is the IUGR criteria. So abdominal circumference, as I told you, is the most important USG marker, and AC drop into less than 3 percentile, yes, that is IUGR. Expected baby weight less than 3 percentile is also IUGR. And I had discussed with diagram that sir, absent and diastolic flow or even reversal of flow in the umbilical artery Doppler, it is indicating impending death. And absent flow, reversal of flow, we should go for immediate delivery. Now please understand this. Of course, your radiology teacher will also tell you this better. Pulsatile index more than 95 in the umbilical artery. Okay, here it is uterine artery Doppler. So please understand this. Uterine artery Doppler is more for prediction. Okay, uterine artery Doppler is more for prediction of preeclampsia and IUGR. Okay, that if the pulsatility index is more than 95% in the uterine artery Doppler, or we see a diastolic notch at 16 to 18 weeks, it is a prediction that the mother may develop preeclampsia, baby may develop IUGR. Okay, so this could also be present, but among all this option, that is the safest option to mark, because AC will be definitely less than third percentile, EBW less than third percentile, and absent end diastolic flow on umbilical artery or reversal of flow is definitely the criteria or could be present in IUGR. So pulsatility index more than 95 on uterine artery is the least best option, and therefore that is the option to mark. That is the least in the important the criteria, because uterine artery Doppler, this is the maternal uterine artery. Okay, by the way, this is maternal uterine artery. Okay, so I told you that maternal uterine artery is for prediction of IUGR and preeclampsia. Moving on to the next MCQ. Now here I have got two different recall options. One of the students said that this natural option was there, and some said natural option was not there. I'll tell you both the answers. Okay, so now we have got different types of estrogen. Okay, estradiol, E2 is the most potent. Okay, estradiol is going to be the predominant during the reproductive age group. Okay, so during the reproductive age group, estradiol is the most potent. Estriol is mainly during pregnancy, and we use that unconjugated estriol, E3. Okay, so estriol is E3. Okay, and estrone is E1. Estradiol is E2. When we say estrogen, we mean E2 only. Estrone is mainly in the postmenopausal age group. Less potent. Estriol also less potent. So when we have the most potent, it is estradiol, but that is among the natural. Okay, now suppose if natural is not there, then your synthetic or conjugated estrogen or ethinyl estradiol. Okay, ethinyl estradiol, which we use in ocipil, that is more potent. Okay, so conjugated estrogen or ethinyl estradiol, that is our synthetic progesterones, or artificial, as you want to call it, synthetic or artificial. Okay, so you can decide. I have given both the answers because I tried to get this. Many students said that's a natural word was there. Some are very much surely saying that's a natural word was not there. Okay, so natural. So all these three are natural estrogens. Okay, so estrogen, estradiol, E2. Okay, E1 is estrone, E3 is estriol. All these are my naturally occurring estrogen. Which phases also we should remember? E2 is mainly in the reproductive age group, and non-pregnancy. Pregnancy, it is estriol which is dominant, and estrone is mainly in the postmenopausal, but E2 is the most potent. Okay, most potent natural. Okay, synthetic or artificial, of course, has got more potency. So A could be the answer if the word natural is there. If the natural word is not there, then your ethinyl estradiol was the option, I think, or conjugated estrogen, that becomes the potent, because they have got more affinity. That is how we have created the molecules. Okay, so molecules are made in such a way that they have got more affinity for the estrogen receptors. Okay, yes. Now this again was a repeat. Painful vesicles on the genitals. We don't have all the option, but yes, that is herpes, and we don't give vaginal trial. We should go for LSCS. Okay, LSCS is preferred when there is painful vesicles, so it's called herpes genitalis. That's the only one with painful blister and vesicles on the genital area. Very straightforward. Even your dermat teacher would tell you this. Okay, moving on to the next MCQ, mix of pharmac and OBGY. Yes, that's when the baby is dead, IUFD, after delivery. Okay, after delivery, we deliver the patient, of course, and as I told you, prolactin is going to be on the higher side. So breast engorgement is because of increase in prolactin levels. Okay, and I want to suppress the prolactin levels, and cabergoline is the drug of choice. Cabergoline is better preferred. 0.25 milligram can be given, or even 0.5 milligram can be used. What is done? It's a packet of 4 tablets. and we can just finish it. Normally we give cabergoline once a week, okay, better. This is all PG level, this is all high level, PG level. They're not going to ask you so much stuff, but normally cabergoline is given once a week. But in this cases, because we want immediate treatment for our breast engorgement, 0.25 milligram can be given twice a day for the 2 days. Okay, so you just finish off the treatment in 2 days time and we give it. Okay, so cabergoline, because cabergoline is your dopamine inhibits prolactin. It's a dopamine agonist drug and it is given to suppress the prolactin level. Okay, it is given to suppress the high prolactin levels which is there. So for breast engorgement of basically lactation suppression. Lactation suppression. Moving on to the next question. Yes, again, very happy. So now please understand this, what it was. A quadruple marker test is done at 18 weeks. I told you between 16 to 18 weeks, what are the tests which we do? So between 16 to 18 weeks, the quadruple marker test is done, or the quad test. Okay, quadruple marker test. And please understand this, it is mainly done for trisomy 21 detection, but here it is low risk for trisomy 21. It's very important. Please read this. I hope you all have read this. Okay, sir, the quadruple marker test is considered normal. As I told you, remember in my lecture, that's a quadruple marker test could be high risk or it could be low risk. It's never zero risk. Okay, so quadruple marker test could be high risk or low risk. If it is a high risk test, then what needs to be done? Yes, then I need to go for the confirmatory testing, because quadruple marker test is only a screening test. It is a screening test. So the quadruple marker test is showing me high risk. Then, sir, we go for the confirmatory testing. And what is the confirmatory testing? All of you know, sir, it is by doing karyotyping. Karyotyping should be done, and karyotyping can be done by amnio or CVS. We are at 16 to 18 weeks, then amnio. That's not the question over here. When the quadruple marker test is low risk, then what? Please pay attention. So here for trisomy 21 we got a low risk, but by the way, because alpha fetoprotein could have come high, and that's the reason we got high risk for neural tube defect. Now this is only suggestive. Neural tube defect is a structural anomaly, isn't it? It is a structural anomaly. It's a structural defect, and therefore anomaly scan would be done to detect neural tube defect. It is always detected on ultrasonography, your lemon sign, banana sign. Okay, this is what your radiology teacher will also teach you, lemon sign, banana sign. But basically neural tube defect, it's a structural defect. And what can be done? Folic acid supplementation to be done to prevent neural tube defect. Okay, please understand this. NIPT, or it was your cell-free fetal DNA. This is again the screening test. Okay, amniocentesis and CVS are your confirmatory testing. CVS is done in the first trimester T1. Amniocentesis is done in the second trimester. Okay, and NIPT is also a screening test. It is the most accurate screening test. It's the most accurate screening test. NIPT is the most accurate screening test. Okay, max like almost more than 99% sensitivity, but again it's a screening test. Okay, confirmatory test is only one. Confirmatory test is karyotyping, and this can be done. The karyotyping can be done how? By doing either your chorionic villus sampling or amniocentesis. But that is all for Down syndrome. Here the question was, they've just tried to confuse you by giving all this extra information. Just remember, patient is a high risk for neural tube defect. What is going to detect us? Anomaly scan, because it's a structural defect. That is going to tell me about the ultrasonography will detect about the anomaly, which is a neural tube defect. Amniocentesis would have been done if they would have said high risk for trisomy 21. So the question here was trisomy 21, we are getting high risk. Then what we would have been the answer? Yes, sir. If the trisomy 21 was high risk, then I would definitely do amniocentesis. Okay, because then we are worried about the baby ka genetic problem. So trisomy 21 high risk, we go for amniocentesis. Why amnio? Because it is already 18 weeks. Okay, patient is already 18 weeks. Okay, and very quickly, all of you should also know what are the triple marker test and HCG, alpha fetoprotein, unconjugated estriol, E3. This is the triple marker, and the fourth marker is inhibin A, And in Down syndrome, HCG higher than normal, inhibin A is also higher than normal. Other two are lesser than normal. Then this is suggestive of trisomy 21. Okay, in trisomy 21, the alpha fetoprotein and estriol are lesser and other two are higher. But that's not the question over here. By the way, extra information I've given you that quadruple marker test low risk, that means considered normal, nothing further to be done. Quadruple marker test high risk, please go for confirmatory testing. And NIPT is again not a confirmatory test, it is a screening test and not confirmatory testing. Here the answer, I repeat, is ultrasonography or the anomaly scan, which will detect all the anomalies in the baby. Okay, so I hope all of you had a great time in this session. Do post in if more questions were there. Surprisingly, there was no image based question. That is really surprising, but yes, it can happen sometime because one or two images may come. And as a request, please all of you do subscribe to the OGGuru channel on YouTube. Also, please download the app, and if your exam is far away, then Masterclass NEET PG or FMGE is what you can subscribe to. Different options are available: 3 months course, 6 months course, and even 12 months course. Those who are final year students can go for the 12 months course. If your NEET PG is next year, also go for 12 months course. If you're targeting the exams in the November INICET, you can take the 6 months course. And those who are immediately going for the NEET PG, for them the rapid revision course is ideal. All the MCQs of the previous years, all clinical case scenarios, and all image based questions are covered, and you will going to really enjoy the lectures, is my guarantee. So do download the OGGuru app, get in touch with me. I'm there to guide you, help you. Best of luck. I hope all of you have done very well in the INICET. Don't get disheartened. Suppose if you've not done very well, immediately start focusing on the NEET PG, and you will do very well. Best of luck. Some options, if at all, if you have got changes and all that, you can get in touch with me on phone and WhatsApp. Will guide you. And otherwise, wishing you all the best for the upcoming NEET PG and all the exams. Do very well and do get in touch with me. Best of luck.